Good afternoon, all the aspirants. The session of trauma and burn is being taken by Dr. Aklesh Tandekar, who is a HOD Depth of Critical Care, Wockott Hospital, Mumbai. Thank you, sir, being with us. You can take over.
Yeah, good evening. So today we are going to take few questions on the trauma and the burns. I hope you all must have gone through the basic protocols of trauma and different injuries that are identified. I hope everyone is synced with me. Can everyone introduce themselves?
All the aspirants, you can unmute your mics or you can drop a text
Yeah,
in the chat
I
box.
have Dr. Mahipal.
Hello, sir. Good morning,
Hi,
sir.
hello. Abhishek, John, Chuku.
Yeah, thank you, sir. Welcome.
Yeah. And Sajid Mukadam. Hi, Sajid. We have El Sayed Salem and Muhammad Irfan.
Hi, sir.
Hi, Muhammad. Ragi Ragab. Hi, Dr. Ragi.
Hello, sir.
Hi. We have Dr. Vijay Jaibal. How are you, Dr. Jaibal?
Good, sir. Doing good, sir. Good
Yeah.
afternoon, sir.
Yeah. Good afternoon. Good afternoon. I think, can we start? Huh? Let's
Yeah,
start from this question. I hope you can start reading the questions and you can come up with the answers, and I'll give you the explanation at the end. Let's take this question. Just a moment. Okay. Can Sajid take this question, please? You would like to sort out these questions, or you want me to read the questions and you would like to answer? Okay, I'll take these questions. Let's start with the first question. If everyone is okay, we can start now. Hello?
Yes, sir. Yes, sir.
Yes, yes. Okay, so let's take this question. Question number one. We have a 37-year-old man transferred to the ICU following motorbike accident, and CT thorax scan an hour earlier showed 3 fractured ribs on the left side of the chest, severe pulmonary contusions, and pelvic fracture was also there, and it was about to be fixed. Shortly after the arrival on the ICU, patient developed severe respiratory distress over a few minutes. His BP was 80/50, and he develops tachycardia. Heart rate was around 140 beats per minute. So what's your first priority? We have options:
Tension
immediate
yeah.
intubation
C,
and
to rule
ventilation.
out tension pneumothorax.
Tension pneumothorax.
So okay, so what will be your immediate priority in this case? Whether you will intubate, ventilate, a rapid infusion of 1 liter of crystalloids, and access response, and urgent evaluation of the chest for sign of tension pneumothorax, or arrange an urgent surgical opinion or noradrenaline infusion. I hope we will be interactive, then only we will be able to really enjoy this session.
B.
Some of you have already answered that this patient has possibly a tension pneumothorax. But if somebody has tension pneumothorax, what are your priorities?
So first
Dr.
to
Sajid? Yeah. Please speak out, yeah. Come on.
so ICD or
Mm-hmm.
so
And
so first to put needle for decompress and then I arrange for ICD.
Yes, I think you're absolutely right. Any patient with a pneumothorax, first in any trauma patient, your protocol is to follow ABCD approach. Okay. So airway, breathing, circulation has to be monitored. We have to follow ABCD sequence. A is airway with cervical spine stabilization. And B is breathing with ventilation. C is circulation with hemorrhage control. And D is disability limitation and neurological assessment. And E is you have to expose the patient and avoid hypothermia. The exposure is to find out any missing injuries. Okay. So this
Right.
patient has fractured ribs on the CT and he's at risk of tension pneumothorax. He has raised intrathoracic pressure. In such patients, unless we reduce intrathoracic pressure, the blood pressure will not come up because of the increase in intrathoracic pressure. There is reduced venous return to the heart, and due to reduced venous return, the cardiac output is reduced and it leads to reflex tachycardia. And when there is reflex tachycardia, these patients will bleed more. If you see the option B, rapid infusion of 1 liter of fluid, and if you see D, surgical opinion, these are reasonable opinion. Basically, if the patient has a fracture pelvis or if there is massive ongoing blood loss, okay, in that situation, you have to do circulatory assessment. Okay, but the circulatory assessment doesn't take a priority. The priority is airway and hypoxia prevention. Breathing assessment is very important. If you see, according to the ATLS guidelines, we have to follow ABCD approach. I hope this is clear to all of you. I hope audience,
Yes,
you
sir.
are all with me.
Yeah,
Yes, sir.
yeah, it's very
Yes, sir,
clear,
yes, sir.
doctor.
It's
Thank
very
you.
clear, sir.
Thank you. Thank you. It gives me some motivation that you are all with me. I hope the justification that I've given you is sufficient for you. Okay, in trauma patient, hypoxemia is more dreadful. Patients may die due to cardiac arrest, but if the patient doesn't receive oxygen, they will have permanent disability. Okay, and that's why there has been emphasis over correction of hypoxemia. Whereas in a cardiac arrest patient, the emphasis is on circulation. Whereas in trauma patients, the emphasis is more on prevention of hypoxemia. Let's go to the next question. Regarding the second question, regarding the usefulness of intracranial pressure monitoring in patients with traumatic brain injury, which one of the following is true? Outcome is improved in patients who respond to ICP lowering therapies. If the CT scan is normal, ICP monitoring is not required. ICP lowering therapies can safely be given empirically without ICP monitoring, or cerebral perfusion pressure can be monitored without ICP monitoring. E is hematoma requiring surgical evacuation occurs at a consequence of ICP monitoring in less than 0.01% of the patients. So what's the answer?
Sir, A.
Can
Outcome
you
improve with.
justify?
Sir,
Do
if you
justification,
maintain.
a short justification.
Yeah, sir. If you monitor the ICP and cerebral perfusion pressure, if you maintain it, I think it's a good outcome, sir.
The outcome will improve.
Yeah, CPP, cerebral perfusion pressure, sir, we maintain actually. Our aim.
Yes, yes. How about the CT scan? If the CT scan is normal, ICP monitoring is not required.
Uh,
No, this is
False in
wrong.
case of normal pressure hydrocephalus.
CT may not show you sometimes the signs of raised ICP. Okay.
yes.
Unless you do contrast CT scan. Plain CT scan sometimes may not be able to give you enough idea that the patient has raised ICP. Okay. You are correct. Option A is absolutely right. Because the raised ICP correlates with increased mortality in traumatic brain injury patients. And patients who respond to the treatment with a fall in ICP have a better outcome. So you have a targeted control in ICP, and but there is no high quality evidence pertaining to that monitoring of ICP. But yes, if you monitor ICP continuously, you will be able to start your treatment rapidly, because the delay in starting treatment for control of ICP will lead to more and more secondary brain injury. Patients with ICP monitoring in situ have better outcomes than historical controls, but no high quality evidence has been demonstrated better outcomes as a result of ICP monitoring per se. ICP measurement is required by definition for cerebral perfusion pressure measurement. Okay, as we know that cerebral perfusion pressure is directly proportional to mean arterial pressure
minus
minus
ICP.
intracranial pressure. And then hematoma evacuation, surgical evacuation, or ventriculostomy. These are some of the treatment measures that we can give. A normal CT brain scan is associated with reduced risk of raised ICP in comatose traumatic brain injury patients, but is not highly sensitive. The incidence is 13%. Okay. In one series, they have studied that 60% of the patients may not have abnormal CT scan. Okay, let's go to the next question then. Can somebody read and come on quickly? I want your participation, buddy. It's not me speaking, but you should speak. Come on.
Okay. Regarding unstable fractures of the pelvis, which one of the following options is true? A, falls from a great height are the commonest cause of injury. B, mortality is as high as 45% in hemodynamically unstable patients. C, associated intra-abdominal injury is unusual. D, pulmonary embolism from pelvic deep vein thrombosis is the commonest cause of death. E, arterial embolization has no role in the management of pelvic bleeding.
So what do you think? What is the answer here?
So mortality high in a hemodynamically unstable patient, 45%. B.
Is it associated with hemodynamic instability?
So
Yes, in
unstable
case
fracture.
of bleeding, unstable
Yes,
fracture.
there are two types of pelvic fractures, open book fracture and closed book fracture. Open book fracture can accommodate more than 2.5 to 3 liters, even half of the blood volume can be accommodated. So open book fractures are very dangerous. Okay. And basically patients with pelvic fractures, they bleed through pelvic sacral plexuses. Okay, so the answer is B. The commonest cause of serious pelvic injury is motor vehicle accidents and followed by falls from the height. So majority of the pelvic fractures are from motor vehicle accidents. And the mortality is high because of the torrential bleeding. And there can be serious pelvic injury which may be associated with intra-abdominal injury, especially injury to the bladder, injury to the kidneys is very common in these patients. And sometimes these sacral venous plexuses, they keep bleeding even if the pelvic fracture is united or you have fracture reduction, still these patients will keep bleeding from these sacral plexuses. So you may have to take this patient for embolization. Okay. And sometimes these patients are at risk of deep vein thrombosis also. So IVC filter also may be required in these patients. So arterial venous embolization will stop the bleeding, and fixation of the pelvis will also allow the venous bleeding to stop. Okay, let's take next question. Yeah, somebody please take this question. Yeah.
So,
Okay. Which is the true statement regarding the anesthetic management of a patient with major burns? A, awake fiber optic intubation is the technique of choice in the patient with stridor following inhalational injury. B, a high ventilator minute volume will be required. C, intramuscular morphine is ideal supplemental analgesia for burns dressing changes. D, non-depolarizing muscle relaxants should be given in small doses. E, theater temperature should be maintained at 37 degrees Celsius. Okay.
So,
Okay, so what is your answer?
sir, awake fibrotic could be. I'm not sure, but I think
Awake fiber and optic intubation.
technique of choice of the stridor and inhalation injury.
How about non-depolarizing muscle relaxant?
It is
It should be
contraindicated.
I think that should be the correct one, D.
D, okay.
Depolarizing muscle relaxant should be given, or non-depolarizing muscle relaxant should be given?
Is non-depolarizing. Well, we can use depolarizing within
Saxilin
the
we cannot
first
give, no, sir.
48 hours. or
Acetylcholine
so.
is depolarizing agent. It is
we
not a
cannot give that.
non-depolarizing agent.
Yeah. That is
Okay.
contraindicated.
And the temperature management is also very important in these patients. The answer is B.
B, sir?
Wow.
Why high minute volume?
Yeah.
The high minute volume may be required in these patients. So let's see the answer. So in patients with impending upper airway obstruction, fiber optic bronchoscope may occlude the narrowed airway and cause complete obstruction. An inhalational induction or rapid sequence induction are preferred techniques depending on the experience of the anesthetist. Increased carbon dioxide production will be a feature of the hypermetabolic phase, and therefore minute volume will need to be increased if normocapnia is to be maintained. Morphine has relatively slow onset and long duration of action. Shorter acting opioids such as fentanyl is preferred. And in addition, absorption kinetics of intramuscular injections are unpredictable in such patients. So analgesia should be titrated intra-IV. Large doses of non-depolarizing muscle relaxant may be required as burn patients are resistant to their effects from 1 week post-burn. So while a warm theater is mandatory to prevent heat losses, 37 degrees would be intolerable for the healthcare staff also. So inhalational induction or rapid sequence intubation is preferred technique in these patients. These patients also have increased CO2 production, okay, because of the hypermetabolic state and inhalation of these toxic gases, and especially carbon dioxide is retained. So in order to remove the carbon dioxide, okay, the minute ventilation has to be increased. So respiratory rate also has to be increased to have CO2 washout. So, but the CO2 washout will be temporary. It will not be, long term. Hyperventilation can be done only for some time, because if you continue hyperventilating this patient, it will cause cerebral vasoconstriction and cerebral hypoperfusion. Dr. Mohammed has raised the hand. Can you speak, Dr. Mohammed?
Yes, thank you, sir. In case of inhalation injury, carbon monoxide is much more important than the carbon dioxide, as far as I know.
Yes.
So, in case of, for that reason, we are choosing here the high minute ventilation, volume ventilation in this. Why not fiber optics in this question?
So basically, yes, that answer is also right. You can say partially right, because you have to preemptively intubate these patients. Somebody who has already had burns, major burns, there will have airway compromise. Even fiber optic bronchoscope also, negotiation may not be possible. So these patients may need direct tracheostomy. Fiber optic bronchoscopy will not be possible, dear Dr. Mohammed, because there will be significant airway
Yes.
edema due to those major burns, no? So fiber optic intubation will be of no use. You will not be able to intubate this patient. you will directly have to do a tracheostomy. Okay.
Yes. Thank you, sir.
Cricothyrotomy will be the treatment of choice. Even surgical cricothyrotomy will be preferred in these patients. Just okay. So fiber optic intubation will also lead to a lot of trauma. You will fiddle around. You need a lot of expertise, experience. These are important factors. Huh? And yes, patients with burn will have carbon monoxide toxicity. They will need high oxygen concentrations. You may have to give oxygen concentration at 1 ppm or maybe higher than that. 100% oxygen support should be given to these patients. Okay. And another question is intravascular morphine may not be a good option here because the perfusion will be compromised. There will be significant capillary leakage. The absorption of the morphine will be compromised. And scoline, succinylcholine is a depolarizing agent. It should be avoided as far as possible because that will cause muscle injury, rhabdomyolysis, and these patients will bleed more. I hope this justification is sufficient.
Yes.
Yeah.
Guys, you are all okay with me?
Yes, sir.
Yes, we are.
Yes, sir.
Let's
Okay.
progress.
Great. So you will not make mistake by putting fiber optic tube to this patient. Okay, let's take this question. Next question. Sorry. Yeah. Somebody please take this question.
Okay. A 55-year-old man is admitted to a major trauma center following a motor vehicle collision. He is taken to theater for damage control surgery. The massive transfusion protocol is activated. Intraoperatively, he receives 8 units of packed red cells, 8 units of fresh frozen plasma, and 8 pooled doses of platelets. The surgeon has clamped a bleeding vessel, but reports that the surgical field continued to ooze. A thromboelastogram is performed and shows arrow time 10 minutes, K time 3 minutes, angle 62, maximum amplitude 71, clot lysis at 60 minutes is 11%. Given these results, what is the most appropriate blood product / medication to administer to improve hemostasis? Okay. We have
So from this thromboelastogram finding, so what major bleeding problem do you think here?
Problem in the platelet count because here the clot lysis is usually 60 minutes at 11%. It is much more. So
Okay.
thrombocytopenia is there. We have to give the cryoprecipitate.
Cryo?
Anything else?
the
So
clot
you feel that
lysis time.
patient has
Clot lysis time is
thrombocytopenia.
also prolonged. It's supposed to be less than
FFP.
8%,
Excess
but we
fibrinolysis.
have 11% there.
I think A is the answer. FFP.
You would like to give FFPs or you would like to give fresh frozen plasma, sorry, cryoprecipitates,
FFP. I think.
platelets, recombinant factor 7 or tranexamic acid? What will be the most appropriate answer here?
I think it's platelets.
Let's see
Sorry
the
for
answer.
it's A.
FFP, sir.
Fresh frozen plasma.
Yeah. Have you seen the R time?
So
Our
our
time
time
is
time
10 minutes.
normal.
R time is 10 minutes.
It's
K
not more
time
than
is
10 minutes.
Huh?
Our time is normal K time. Here only the 30 minutes. It's usually in the graph. It's 30 minutes Here,
Okay.
it's 60 minutes in 11%. It is increased.
So how much is the normal hour time? The normal hour time is around 4 to 8 minutes.
Yes.
Okay.
Two-
And you have a K time which is around 1 to 4 minutes. Here K time is how much? Here R time is definitely prolonged. Huh?
Yes,
R
sir.
time is
Our
10
time is
minutes.
prolonged.
10, sir.
And the clot lysis time is also prolonged.
Yeah, clot lysis time is 11%. Okay. Okay. K time is 1 to 4 minutes, which is near normal. Okay. The angle is around 47 to 74%. So what about the angle here? It is 62%. So that is also normal. So generally the R time shows you about the clotting factors. The angle tells you about the level of the fibrin. Okay, fibrinogen. Okay. And the amplitude MA time tells you about the platelet count. And clot lysis time tells you about fibrin degradation product or DIC. So now here you see the clot lysis time at 30 minutes and 60 minutes shows clot stability and fibrinosis. It is around more than 15%. Then only you call it as hyperfibrinolysis or DIC. But here it is less than 11%. So this patient doesn't have DIC also. You got it, no?
Yes,
Yes.
yes.
So
Now it is clear.
the clot lysis time is 11%. Generally, it should be more than 15%. So clot lysis time is normal, means patient's fibrinolysis is not going on. So DIC is not a feature here. Even angle is also normal. So this patient's fibrinogen is also normal. K time is also normal. So only the R time is prolonged, means this patient's clotting time is prolonged. Clotting time is prolonged, means this patient has clotting factor deficiency. So which clotting factor deficiency will lead to prolonged R time? Factor 2, 7, 9, 10. These are the factors which are responsible for clotting mechanisms. Okay. So you will have to supplement this thing, FFPs to provide clotting factors. Cryoprecipitates will also contain clotting factors, but it will contain more of fibrinogen. Platelet will correct platelet count, and recombinant factor 7 will be also useful. It can also be useful. Dr. Mohammed, you have raised the hand. Can you?
Yes, yeah. In the first academy, where there is question that this explanation is right, but in that it has to be corrected.
Yeah, pardon? What has
In
to
the
be corrected?
explanation. In the first academy website, this question is available, but this explanation written here is corrected, but in that answer sheet in the first academy online website, the explanation is not right. Please correct it.
Oh, sure.
Actually,
Sure.
sir, we'll be uploading all the answer PPT in the portal after the session, after 15, 16, and 17. We'll be providing you every answers for it. Thank you.
I hope the explanation that I have given you is okay
Yes,
for
sir.
you.
Yes, sir. We'll be uploading it.
You got this?
Thank you, sir.
Yes,
Huh?
sir.
I
So,
hope I have given you correct explanation.
Yes, sir. Thank you, sir.
So, sorry, when we
Yeah.
give platelet, sir, what, which factor, sir? When we give platelet, K more or what?
MA, this maximum amplitude. Okay.
Okay.
This maximum amplitude, if the maximum amplitude is small, here the maximum amplitude is around how much it is? Maximum amplitude is 71
71.
millimeter.
Morning.
71.
Yeah.
So, if it is
So,
small, if we give platelet.
yeah, if the maximum amplitude is around 55 to 73, this is the normal.
Okay, sir.
Okay. And if the maximum amplitude is more than 73,
Yeah.
that means there is platelet deficiency. Sorry, if it is less than 55, then there is platelet deficiency.
Okay, sir.
Okay. And if it is
Right, sir.
more than 73, maximum amplitude will be more.
Yeah.
Okay. So
Right, sir.
there are 3-4 factors that are supposed to be seen in thromboelastogram.
Yeah.
First is R wave. R wave
Yeah.
is like a tail. Look at it. If the R wave
Yeah.
is prolonged more than 10 millimeters, it means the clotting factor deficiency. Then
Yeah.
you look at the angle.
Yes,
Generally,
sir.
the thromboelastogram is like this tail, and then you will have a spindle shape.
Yeah.
Okay. And then angle is very important. If it is a very acute angle, it means there is fibrinogen deficiency. And then you see the MA value. What is the that spindle shape of the spindle? Okay. And then
Right,
it
sir.
has to has a tapering end. If the
Yeah.
tapering end gets prolonged, it means the patient has hypofibrinogenemia, usually seen in DIC. Hmm? Okay.
Right, sir.
Okay.
Right.
Very
Thank you, sir.
important. You will have these questions in EDIC. Okay. Can somebody please take this question quickly? Yeah.
A 91-year-old man falls in the garden and sustained fracture to ribs 4 to 6 on the right side and a small pneumothorax, which is managed conservatively. He has no other associated injuries and there is no evidence of myocardial or pulmonary contusions. His past medical history includes ischemic heart disease, previous myocardial infarction, and chronic obstructive pulmonary disease. His medication includes aspirin and clopidogrel. He is managed on the surgical ward for 24 hours, and then a request is made for assistance with the analgesia. In addition to the regular paracetamol and NSAIDs analgesia, he is already receiving. Which of the following options would be the best choice for pain management in this patient? Paravertebral block, intercostal nerve block, thoracic epidural, Antonox, and change from oral to intravenous paracetamol.
Mhm. So what do you think is the answer?
Intercostal nerve blocks?
Yeah. I think.
Why not epidural?
Because it's
Patient
taking
oncology.
antiplatelets. So the risk of spinal hematoma is high in this patient.
Yeah, because
Otherwise, a thoracic epidural would have been the ideal for pain relief.
Yeah.
But the use of these double platelets, I think it's a major contraindication to thoracic epidural and paravertebral block.
absolutely, because this patient is already 91-year-old.
Yeah.
He has he's on antiplatelets. He has ischemic heart disease, myocardial infarction. Okay, he's on ecosprin clopidogrel. It has to be stopped for at least 3 to 4 days before you do any procedure. So you cannot do that paravertebral block. Thoracic epidural also is not possible. Entonox. Would you like to give Entonox to this patient? Entonox is a combination of helium and oxygen, which will help the patient to breathe. But it will not give you.
It's nitrous oxide and oxygen.
Yeah, it doesn't give analgesia. Huh? It will help you to breathe better, but it will not give you enough analgesia. And
Sir,
oral
actually,
paracetamol, whether he'll be able to, only paracetamol will be sufficient? It won't be sufficient.
yeah.
Huh? So the answer is absolutely right. Huh? Good. Kudos. This patient, elderly, is at risk of developing respiratory distress and complications due to his medical history and number of fractures that he has sustained. So whenever you have 3 or more rib fractures, the rates of complication and mortality increases significantly. A good pain relief is very important. So whenever you have a skin, soft tissue, or bony pain, no, NSAIDs are best. When you have visceral pain, abdominal visceral injury, then you have the option of opioids. The opioids are better. Okay, but sometimes, but if the pain score is more, generally the pain score is graded as 0 to 1, 0 to 10. Okay, so if the pain score is between 0 to 3, NSAIDs is sufficient. But if it is 3 to 5, you have to give opioids. And if the pain score is more than 5, you have to give opioids and NSAIDs in combination. And if the pain score is more than 7, you may have to use regional anesthetic agents. So this is called as multimodal analgesia. Okay, I hope you remember this pyramid of pain and pain cycle also. You should know pain cycle. So generally the pain cycle has peripheral component and the central component. The peripheral component, whenever you have injury on the hand, there will be release of prostaglandins and A delta and C fiber is stimulated. That will carry the signal to mu receptors in the spinal cord. Okay, and then from spinal cord, the impulses will go to the brain. Okay, at thalamus, you call it as spinothalamic tract. There you have GABA receptors. Okay, and then from GABA receptor, it will go to the cortical areas where the intensity of the pain will be interpreted. And then you will have withdrawal. And the same signal will carry from cortex to the periphery. Initially from corticothalamic and thalamo spinal tract, it will go to the hand. So you have to break the pain pathway. You have to block A delta C fibers. For that, you need NSAIDs. You need to also block mu receptors in the spinal cords located at substantia gelatinosa. For that, you need to give opioids. And for brain, you will have to have GABA receptor. So unless you use these multimodal analgesia, blocking pain receptors with NSAIDs, opioids, or GABA antagonist, the pain cycle is not going to be broken up. So that's why this is how you will control the pain. Can somebody take this next question, please? I hope I was very clear. Come on, guys. We have 10-15 minutes left only. Dr. Anup. Dr. Anup.
Just show us the next question. We are still on the last one.
Yeah, pardon?
So no,
Display the
this
next
screen.
Question number 7. It is 6 now.
Next question, not there.
Okay, I'll read.
Yes.
Okay. Regarding,
Yes.
all right, regarding acute traumatic cardiac tamponade, the following are true, except A, it is more common in penetrating than blunt trauma. The jugular venous pressure may be normal. A fall of more than 10 millimeter mercury in systolic blood pressure during inspiration defines pulsus paradoxus. An enlarged cardiac silhouette.
Sorry, I am very sorry, dear.
It's okay, sir.
I think the answer also got displayed.
Yes,
Yeah.
sir.
Okay.
We will have discussion on this. This is more important rather than any answer, no? Yeah,
Yeah.
you try and attempt and give explanation to all these options. That is better, huh? Yeah.
Yeah.
True.
Please read, yeah.
Okay. So an enlarged cardiac silhouette is seen on the chest X-ray. ECG findings of electrical alternance is pathognomonic of cardiac tamponade.
So what
that's
what is your best answer for this?
Actually, we already seen the answer. This is JVP
but
should not be
still,
normal,
give
sir.
me justification. That is more important.
Yeah, so JVP should be full. It should be full, sir, actually.
Yeah. So basically, a patient with a cardiac tamponade will always have a Bextrade. I hope you're aware of the Bextrade.
Yeah.
Yeah.
They will have
Sir,
raised
why
JVP.
D?
Pardon?
Why D? Answer is B.
I'll tell you. Except, no, there is an option except. All are true except. Okay, so these
Well,
patients.
I
Professor
think
will be.
I can offer an explanation for why I think it's D. Because this traumatic cardiac tamponade is acute, and the cardiac silhouette may not, the heart may not, we need some time to get sufficiently enlarged,
Yes.
to give the classical, X-ray signs in cardiac pericardial effusion.
Oh, yes. Absolutely. See, I would like to just add something on this. Just a moment. So basically, cardiac tamponade is usually seen with penetrating trauma, and usually there is injury to the heart, the pericardium is injured, and there is collection of blood in the pericardium. So the hallmark of cardiac tamponade is there will be raised JVP, which is one of the big stride. The heart sounds will be muffled, okay, and the blood pressure will be low, the pulse will be low. These patients, initially they may tolerate the hypovolemia well, but later on, once the tamponade increases, there is equalization of pressure inside all the chambers, okay, and there will be the outflow which will be compromised. The heart will not be able to eject the blood into the aorta or something like that. So basically, this is not very rare. Okay, it is usually seen with thoracic and abdominal trauma, and basically these patients will also have electrical alternance, where in the ECG you will see the change in the voltage of the P wave and Q RS complex and T wave due to the heart which is swinging inside the effusion, because there is a large collection around the heart, and the heart will be moving inside that bag which is collected with the blood with the tamponade. So due to that swinging of the heart inside that tamponade bag, there will be change in the ECG which will also swing. So that's why the waveform of the P wave, QRS complex and T waves will also change. It will keep fluctuating. So the treatment of tension thorax, cardiac tamponade. What is the treatment of cardiac tamponade? So the treatment of cardiac tamponade is pericardiocentesis.
Synthesis, yes.
But sometimes the pericardiocentesis may not be sufficient. You may be prepared to take this patient to operating room, and surgical evacuation of the tamponade also very important. If you place a pulmonary artery catheter in patient with cardiac tamponade, you will see that these patients will have a prominent V wave and prominent X descent. Okay, if you have a central venous catheter, you see the CVP waveforms, no? In the CVP also, you will see prominent X descent and prominent Y descent. And when you place a pulmonary artery catheter, the pressure inside all the chambers will be equal. If you do send the patient to a cath lab and you try to measure the pressure inside all the chambers, there will be equalization of pressures in all the chambers with the cardiac tamponade. So this is one of the hallmark of cardiac tamponade. It is one of the life-threatening situation, needs to be handled in a comprehensive trauma center where you have a surgical facility available, and the cardiothoracic surgeon should be involved. Anyone would like to add anything else?
So the answer is B or D? What is this?
Okay. So usually these patients will have pulsus paradoxus because the blood pressure will fall during inspiration. The fall in the blood pressure is more than 10 millimeter. So the cardiac silhouette, you will have to see the cardiac silhouette will be normal, but there will be enlargement of the heart shadow due to that pericardial effusion. They're not asking about whether the heart, they're asking whether the heart is enlarged or not. The heart will be normal. The heart size will be normal, no? It is due to this pericardial effusion, the heart shadow will look like a big shadow.
Okay.
You will have a water bottle like appearance or pericardial effusion. If you see pericardial effusion, you will see there is a water bottle kind of appearance. Similar appearance will be seen in patients with a cardiac tamponade. But the heart, you will be able to distinguish heart from the pericardial tamponade. The cardiac silhouette or the cardiac shadow will be normal in the chest X-ray. Okay?
This is the answer. Accept. Okay.
I hope you understood. The heart
Yes,
size
sir.
is normal, nobody.
Yes.
It's
Heart
very
size is
clear.
normal. It is not a dilated cardiomyopathy, or it is
Yes, sir.
not a left ventricular hypertrophy where you will see enlarged cardiac seal out. Got
Yes,
it,
sir.
no?
Yes.
Okay, so this is the pericardial effusion, which will
Yes.
result in enlargement of the shadow that you will see, but the heart per se will be normal. Okay,
Yes, sir. Got
so
it, sir.
let's take this next question. Come on. Regarding
Okay.
fluid resuscitation of the trauma patient, which statement is false? Can somebody come up with the answer, please? Is it very difficult question?
Reading, sir. Actually.
Answer is B.
Yep.
Can you just give me any justification for this answer? You're right, buddy. So any patient with a trauma, the dictum is pre-warmed crystalloid, balanced crystalloid, 1 liter. This is the recommendation. ATLS guideline recommends 1 liter of pre-warmed crystalloid, lactated ringers. Okay. So overzealous fluid resuscitation should be avoided, and your target blood pressure should be less than 90, or mean arterial pressure should be around 60. Because if you give excessive fluid, what will happen if you give excessive fluid? There will be dilutional thrombocytopenia, dilutional coagulopathy, and the patient will bleed more if the fluid is not warmed enough. Okay. And if there is a tamponade effect of a clot sitting on a bleeder, that clot will also get dislodged if you give excessive fluid.
Yes.
So the crystalloids, balanced crystalloid is recommended here. Hypertonic saline has not shown to increase any survival compared to crystalloid. Okay. Hypertonic saline is not recommended here. Here you have to use a fluid which will fill the deficit. Hypertonic saline is used for correction of hyponatremia. These patients may not have hyponatremia. Okay. And, arterial base deficit is one of the predictor of resuscitation adequacy. Urine output, pulse capillary refill time less than 2 seconds, patient's consciousness, improvement in patient's consciousness, improvement in patient's heart rate, improvement in urine output. Okay, these are some of the markers of patient's response to the resuscitation in trauma. Lactate is also one of the better indicator of adequacy of fluid resuscitation. But the trend of lactate is more important rather than one value of a lactate. You should serially see the lactates whether it is improving or not. And the base deficit clearance also has been associated with improvement in survival. If the lactates improve within 6 hours to normal, that itself is an independent predictor of survival benefit. If the lactate doesn't come back to normal within 6 hours, this patient is not going to do well. Okay, got it?
Yep.
Yeah.
I hope this explanation was good enough for you. Yeah, Dr. Mukaddam, please, you can ask the question. Dr. Sajid, you can ask the question, please. You have raised the hand. Hello. Okay, till the time, can we take this next question, please?
A
Yeah, please.
45-year-old man with diffuse axonal injury and a GCS of 7 on presentation has been sedated and ventilated on your ICU for the past 24 hours. He has no other injuries of note. Intracranial pressure monitoring has not been instituted. Which one of the following statement is true? PEEP is contraindicated. Partial pressure of carbon dioxide should be maintained at 4 to 4.5 kilopascal. Thiopentone is the sedative agent of choice. Plasma osmolality should be kept below 320 milliosmol per liter. MAP should not exceed 90.
So can you justify each option, please?
PEEP is contraindicated. Sometimes in another journals that said at least minimum 2 to 3 PEEP is needed, or otherwise the partial pressure of carbon dioxide can be increased. I think partial pressure of carbon dioxide should be maintained 4 to 4.5. That means 28 to 32
Yeah.
millimeter of mercury. Thiopentone is the sedative agent. It's true, plasma osmolarity. Answer is B.
Thiopentone is
B. Answer is
basically
B, sir.
for seizure prophylaxis.
Yeah.
It is not
Yes.
a sedative
Sorry,
agent
yes,
of
sir.
choice. And plasma osmolarity below 320 is also not advisable. It should be
Yeah, it's
between
more.
310 to 320.
Yeah.
Okay. And mean arterial pressure should be between 90 to 110.
Yes.
Patient with a traumatic brain injury, you have to keep mean arterial pressure as high as possible, because the cerebral perfusion pressure depends upon mean arterial pressure
Plus
minus
minus
intracranial
IC.
pressure. Okay. And PEEP, PEEP, no, you can keep normal PEEP. You don't use high PEEP, because if you keep the high PEEP, the intrathoracic pressure will increase. And then that intrathoracic pressure will get transmitted to the brain and it will increase intracranial pressure. The PEEP has to be minimum. Normal PEEP of 5 to 6 is recommended. And hyperventilation is also not recommended. PCO2 should be kept between 30 to 35. Okay, but excess of PCO2 is also avoided because it will increase cerebral edema. And the sedative agent of choice in patients with a traumatic brain injury is propofol, not thiopental sodium. Okay.
Yes.
And you will have to target the sodium of around 145 to 150. You will have to keep high sodium, high serum osmolarity of around 310 to 320, and avoid hypercapnia and hypoxemia. And you
Some
have to
book says
also avoid
155.
fever. Pardon?
Some book says serum sodium is 155, up to 155.
Yeah, but yeah, 150,
So
155 is reasonably
which I will
acceptable.
choose, 150 or 155?
155 is also acceptable, but do not let that sodium level go beyond 155.
Okay, thank you, sir.
Yeah. You can accept the sodium between 145 to 155. But to be on safer side, the sodium above 155 is quite dangerous. So that's why some books also mention 145 to 150 and 155. Some books mention 155 also. But you have to consider patient's clinical condition. Okay. Okay. Can you somebody take this question, please? Next interesting question. Yeah. Some other participants can also take this question. We have Dr. Arun Prasad. Can you take this question, please? Dr. Anup Datta.
Which statement regarding transfusion-related acute lung injury, Jolly, is true? A. Volume overload is a principal problem. Mortality ranges from 5 to 25. It's an immunological diagnosis. It is IgE mediated. Rally is physiologically distinct from acute lung injury. A. Volume overload is a principal problem.
So D, IG mediated.
IgE mediated? No, it is not an hypersensitivity reaction. It is an antibody mediated reaction.
Okay.
So basically, transfusion-associated lung injury is a clinical diagnosis of exclusion, usually seen with large volume resuscitation, or even a single blood transfusion or FFP can also contribute to transfusion-associated lung injury. So basically, there is development of the antibodies. These antibodies target the lungs and cause capillary leakage, and these patients will develop non-cardiogenic pulmonary edema. the treatment of choice for patients with the trally is you have to give steroids, diuretics, and ventilate the patient, or you can give non-invasive ventilation with high PEEP. So these are some of the options that you can provide any patient who is coming with transfusion-associated lung injury. So that's why we have to avoid blood and blood products as far as possible, unless it's very, very urgent or essential. Because even a single FFP or single PRBC or even platelets can contribute to transfusion-associated lung injury. So generally nowadays we see the blood products are available. These components are washed, but sometimes the antigens are not antigens, or the antibodies which are there, they are not completely washed off. The residual antibodies in the blood components can contribute and trigger the hypersensitivity reaction, and the recipient can mount a reaction against these blood products and can be life-threatening also. So now moving on to the K-type questions. These are multiple answer questions. Can somebody please take this question? Dr. Mani, can you please take this question? Hi, Dr.
Sir.
Mani.
Sir, my part.
Yeah.
So 44-year-old man is involved in road traffic accident and is shifted to ICU following fluid and blood transfusion resuscitation. Emergency splenic and external fixation of the pelvic fracture and external fixation of the femoral shaft fracture. On initial presentation in the emergency room, he has in ATLS grade 3 shock and arterial blood gas analysis shows a lactate 6.4 millimole per liter. On arrival to ICU, he has reduced to 3.5 millimole per liter. So this is a type A lactic acidosis. Lactate is a prognostic significance in trauma patient. Venous blood can be used for lactic analysis. Outlook will be poor if lactate remains above. So, sir, here is answer A is true, and B is true, C false, D true.
Okay. Can you just give me justification in one or two sentences?
So, let's type A lactic acidosis because trauma based, sir. And lactate is really, sir, prognostic significance in the patient, sir. Lactate is high.
Serial lactate measurement, huh? And not a
Yes,
single.
sir.
But if the liver
Yeah.
is affected, the lactates may tend to be very high.
Yeah, increase, sir.
Okay, even after the fluid resuscitation, if there is a ischemic injury to the liver or trauma to the liver, the lactate will not come back to normal. So lactate will
Yes.
persistently be elevated. So that will also help you to differentiate a shock versus liver injury. Okay, if it's a liver injury, lactate will not come back to normal. And if after adequate resuscitation, lactate is coming back to normal, it means the resuscitation is adequate.
Yeah, adequate.
Okay.
Yes.
And the lactate can be collected, both arterial and venous blood lactates are accurate enough to give assessment of the lactate levels.
Okay, sir. Venous also same.
Yeah. But if the lactate level does not come back to normalcy, it means the microcirculation is compromised. There is significant anaerobic metabolism going on, and there is a microcirculatory shock, which is a decompensated kind of a shock, where the circulatory mechanisms have failed, or there is a mitochondrial death, where the electron chain system or respiratory system, this electron chain mechanism or ATP production is completely compromised or jeopardized. So in that situation, the lactate is not going to get normal. And if the lactate is not nearing normal and persistently getting elevated, that tells you about tissue hypoxemia, persistent tissue hypoxemia and mitochondrial death. Okay, so can somebody please take this question? Somebody, can I? Dr.
Okay.
Victor, can you take this question, please?
Okay, let me take it.
Yeah.
Okay. A 30-year-old woman presents to the emergency room following a suicide attempt where she's been in an enclosed space with a burning coal fire. She is drowsy with GCS of 13, with a heart rate of 123, blood pressure of 125/95, and oxygen saturation of 96% on high flow oxygen. She has a brief tonic-clonic seizure, which self-terminates. Arterial blood gas analysis shows pH 7.36, PO2 40.6 kilopascal. That's 308 millimeters of mercury. PCO2 4.4, that's 33 millimeters of mercury. Calculated arterial oxygen saturation is 99%. Okay, A, the history and findings are consistent with carbon monoxide poisoning. There is evidence of a saturation gap. Okay. Oxygen therapy should be titrated down to a lower PaO2. Hyperbaric oxygen therapy is contraindicated.
So what is the answer?
So A is correct.
The history and findings are consistent with carbon monoxide poisoning. I
Yeah.
think you're absolutely right.
Yeah.
Because this patient had tonic-clonic seizures and there may be a cerebral edema and there may be excessive carbon monoxide accumulation. Though this patient looks hemodynamically stable, blood pressure is normal, but his heart rate is very high, 123, and he's maintaining his oxygen saturation with high flow oxygens. He may be hypoxemic. Okay, and his seizures terminated after providing oxygen. Okay, and what is more important here in this patient is to monitor the carbon monoxide levels. So your usual ABG machines may not give you carbon monoxide values. And so here you will have to ask specially to your lab to monitor to give readings of carbon monoxide. Or you will also have to calculate alveolar arterial gap.
Gradient.
Okay, the saturation. This is called as the saturation gap or A gradient. If you get the A gradient prolonged more than 20 or so, probably this patient has, some kind of a shunt that is going on. Okay, and then that shunting is basically due to the capillaries which will be diverting blood to the normal lung or aerated lung. Okay, and the treatment of choice for carbon monoxide poisoning is hyperbaric oxygen therapy. If you give, so the treatment is 100% oxygen for 6 hours. We'll try to correct sodium to normal levels. And if you give oxygen concentration at 1 ppm, it will take 1 hour to correct carbon monoxide related toxicities. And carboxyhemoglobin monitoring is very important. So routine pulse oximeter may not be able to give you right values. As you see, the saturation is looking 99%, no? This is false because the carboxyhemoglobin levels and the oxygen hemoglobin levels, this will be misinterpreted by our pulse oximeter because the wavelength is different.
Listen.
So the only confirmatory finding is to monitor carboxyhemoglobin levels. If the carboxyhemoglobin level is, which is seen here, is around, how much is the carboxyhemoglobin level? Have they provided us carboxyhemoglobin level? No. But the carboxyhemoglobin level of more than 40% is pathognomonic of carbon monoxide toxicity. Standard pulse oximeter measures only 2 wavelengths of the light and falsely interprets carboxyhemoglobin and as oxyhemoglobin, and it overestimates the true arterial oxygen saturation. Many blood gas analyzers provide calculated saturation based on PO2 of oxygen in the blood, which is not affected by carbon monoxide poisoning. Hence, this value is also falsely elevated. True arterial oxygen saturation can be measured using coaximeter, which uses multiple wavelengths of the light. So, if measured in this case, the true saturation would be very low when compared with the falsely elevated saturation that we see here. This is termed as saturation gap. Okay, since the saturation provided in this question is calculated, however, this is not seen. Indications for hyperbaric oxygen therapy are carboxyhemoglobin level more than 20%. And neurological signs or loss of consciousness are typically seen in patients with carbon monoxide levels of more than 30%. Okay, let's move on to the next question, please. Oh, sorry. Yeah, come on.
Okay.
5 more minutes and then we will finish. Huh?
Okay. A 28-year-old man receives a stab wound to the upper abdomen. On arrival in the emergency room, he has a GCS of 15 and is in pain with a small puncture wound under the left costal margin. Blood pressure is 80/40. Heart rate is 130 beats per minute. Respiratory rate is 30 breaths per minute. His neck veins are distended. Chest X-ray shows no evidence of pneumothorax or hemothorax. ECG shows right bundle branch block and T-wave inversion in lead V1. A focused abdominal ultrasound for trauma fast scan shows the presence of pericardial fluid. A transthoracic echocardiography is the diagnostic technique of choice when considering traumatic cardiac tamponade as a diagnosis. A CT scan of the thorax should be performed immediately to confirm the suspected diagnosis. Rapid fluid infusion should be avoided to prevent right heart failure. Removal of at least 300 ml of fluid is required to materially improve the clinical condition.
A is true, sir.
Mhm.
Echocardiography. CT
Yeah,
scan.
echocardiography should be done, right?
CT,
CT scan of the thorax
not recommend fast, sir.
not recommended, right?
Fluid, we have to give fluid in right heart failure, sir.
Right heart failure, you have to give fluid. Yeah, it is
Yeah.
preload dependent. No, right heart failure is
Yeah.
preload dependent.
And the amount is not sure, sir. 300 ml fluid.
Too much.
D.
So 300, if you suddenly
Take
remove
off.
300 ml of fluid, the patient will get decompensated. Okay, so you have to remove the fluid gradually. And in this situation, you will have to place a pigtail. Okay, you keep the pigtail and keep draining it gradually.
Yeah.
Okay,
Right.
because the right heart and there will be sudden flash pulmonary edema also because of the sudden removal of the tamponade that can cause flash pulmonary edema also.
Yeah.
Okay, so let's move on to the next question. Yeah, sorry. Yeah, can somebody take this question, please? 34-year-old man involved in car accident, high speed. He is a driver and is wearing seat belt. He is neurologically intact on arrival in the emergency room, but hemodynamically unstable and has positive diagnostic peritoneal lavage. He also has bilateral closed femur fracture and he is taken to operating room for emergency laparotomy. So what is the answer?
So A is damage control surgery, not the definitive surgery. That should be wrong. Because we go for the damage control surgery first. Then surgical surgery with femur fracture should be deferred until later date. Femur fracture should be stabilizer.
C is correct.
Hollow viscous injury must
yeah.
be dealt with. Yeah. Abdomen must be
Abdomen must be closed to prevent overwhelming.
No, it's not
Abdomen must be
mandatory.
closed. D is false.
It's false, yeah, because we need to open to abdominal pressure maintain, abdominal, intra-abdominal pressure.
Yeah, because if it's closed, you might even have abdominal
More,
hypertension.
yeah, more IAP and perfusion
Yeah,
and ischemic injury
intra-abdominal.
of the bowel.
So A is false.
Yeah, A is false. B, surgical
B is
intervention.
true.
Okay. Hollow viscous.
C is
Yeah.
false. D is false.
Okay. So definitive surgery must be performed? No.
Okay.
This patient should be transferred to a definitive trauma center. All polytrauma patients should be transferred to a definitive trauma center rather
Okay.
than taking these patients and keeping these patients. The golden time will be lost and the patient will bleed more, and we will not be able to do the justice. Okay, because if you don't have a comprehensive care and the trauma team is not available, the treatment will be haphazard and there will be a lot of missing injuries which may get unnoticed and untreated. Okay, this patient is a major polytrauma patient. This patient has coagulopathy, hypothermia, and metabolic acidosis. These are some of the risks that may get that may be exacerbated. If you do the prolonged surgery and if you delay the surgery in these patients. So basically, that's why initial surgery should consist of a damage limitation surgery only, which may involve only packing and controlling the bleeding with the tamponade effect rather than any formal resection. Debridement of pancreatic injury rather than pancreaticoduodenectomy or resecting non-viable bowel and stapling the ends rather than attempting a primary reanastomosis. This patient also may need reoperation for definitive surgery later on because the prolonged surgical procedure can lead to coagulopathy and DIC kind of a picture. So it's better to pack and then open up later on. So re-exploration can be done after 24 to 48 hours.
Okay.
Meanwhile, the fluid resuscitation, acidosis, coagulopathy can be corrected. And the fracture should be stabilized early because this patient has ARDS and multi-organ failure. So intramedullary reaming, however, can worsen lung injury because of fat embolism. This patient may have fat embolism. So these procedures can also be done later on. And external fixation is preferred rather than drilling the bone. The external fixations are better. And abdominal closure may provoke abdominal compartment syndrome, which has high mortality. So that's why basically in such situations, you may have to apply a Bagota bag. It is like a decompression of the brain surgery. The decompression of the abdomen is done. Apply a Bogota bag. Allow the bowel to settle down. Till that time, the bowel, which is edematous, will also shrink. And your resuscitation and coagulopathy can also be corrected. And later on, you can operate this patient. Okay. So I think these are the questions that you may be asked in the exam. So we'll take this last question and then we'll wind up. We're already exceeded the time, please. Can somebody take this question, please?
A 32
A 32 year. Okay, go ahead.
Please proceed.
Go ahead, brother.
Okay, a 32-year-old woman suffers a liver laceration in road traffic accident. During laparotomy, she bleeds extensively and requires 15-unit blood transfusion. Post-operatively, she is transferred, ventilated to the ICU, where she develops progressively worsening lung compliance and hypoxemia. Partial pressure of oxygen is 68 millimeter of mercury on FiO2 80%. Over the next few hours, chest X-ray shows widespread fluffy infiltrates. The pulmonary artery occlusion pressure is 15. The chest X-ray may be consistent with pulmonary edema. Diuretic therapy is indicated, corticosteroid is indicated. Sufficient information is available to diagnose transfusion-related lung injury. So the answer is
A is correct, B is correct, C is wrong.
No, actually, A is wrong because it's not pulmonary edema. Because
A is wrong because the patient
But
has a
the
road traffic accident,
because
liver laceration, every possibilities of ARDS.
yeah, because PF ratio is less than 100.
Less than
ARDS.
100. So the diuretic therapy is not so indicated.
Not
Corticosteroid
indicated.
is indicated. You
No,
have
I
to
think
give
a corticosteroid to
steroid.
give in ARDS.
So this is
ARDS.
transfusion-associated lung injury. We have already discussed. These patients will need everything. So this
Okay.
patient X-ray may not be consistent with pulmonary edema. This is true. Diuretic
but
therapy may not be required, and steroids may not be required. Only when the patient is extremely hypoxemic, 100% oxygen requirement, or you have to prone this patient, or probably the injury is significant, then only corticosteroids are recommended. But routinely, these steroids are not recommended. And this definitely is autoimmune antibody related injury, which is causing a capillary leakage and third spacing, and there is leaking of the there is leakage of the fluid into the interstitium. So basically, this is the diagnosis of exclusion. You need to exclude the other possibilities. Okay, your patient has received a lot of blood and blood products. 15 blood products your patient has received. So that itself is a contributory factor for transfusion-associated lung injury. So there is insufficient evidence related to the corticosteroids. This patient's kidneys will be absolutely normal. They will always respond to high PEEP and ventilator therapy and sedation, analgesia, and high PEEP is all what is more important in treating patients with the transfusion-associated lung injury.
okay, let me just say something. Excuse me, sir. We are informed that the pulmonary artery occlusion pressure is 15,
Yeah.
which I think is the reason why the answer A is correct, as saying that
Pulmonary
it's
edema.
consistent with pulmonary edema.
Yes, X-ray may look like pulmonary edema. There will be fluffy shadows. There will be bilateral involvement of the lungs. Heterogeneous shadows also may be there. But it is very difficult to differentiate pulmonary edema from this transfusion-associated lung injury. So the transfusion-associated lung injury will have more of a peripheral distribution rather than the central distribution. Patients with a pulmonary edema due to cardiogenic cause will have central hilar prominence, whereas in these patients of transfusion-associated lung injury, there will be more of a peripheral involvement. So that is one differentiating feature, but it is really difficult.
But the pulmonary artery occlusion pressure will usually be normal in ARDS.
Yes.
Yep.
So this picture will be like ARDS. This picture will be like ARDS. Transfusion-associated lung injury picture is like ARDS. Okay.
But the pulmonary artery occlusion pressure is high. It's more than 12.
So there may be a lot of other reasons
12.
for high pulmonary oxygen pressure. It is due to hypoxemia, hypercarbia, pulmonary hypertension, because when patients has transfusion-associated lung injury, there is injury to the lung parenchyma, and as a result of which there is pulmonary vasoconstriction. And due to this pulmonary vasoconstriction also, the pulmonary occlusion pressure is likely to be high. But a single value of pulmonary occlusion pressure will not be sufficient. Because I agree with you that pulmonary occlusion pressure should be 8 to 12. In mechanically ventilated patient, 12 to 15 of pulmonary occlusion pressure is still acceptable. But a pulmonary occlusion pressure of more than 18 is 18 usually correlate with cardiogenic pulmonary edema rather than ARDS.
Sir, actually, when I answer this question, suppose I take the X-ray chest pulmonary edema is correct. Correct, sir?
Yeah.
So it is very confusional. I make this diuretic therapy indicated. I will put it true, sir, actually. I cannot make it false. If I make first answer pulmonary edema, B, I will think B cannot be false then.
Yeah, it can be. You have to individualize.
Yeah. And third thing, sir.
But diuretic therapy will not be the mainstay of the treatment, huh?
So,
The mainstay of the treatment will be ventilate this patient or non-invasive ventilation and give high PEEP.
yes, sir. That is the one thing, sir.
Yeah.
If pulmonary edema, so diuretics should be the answer. I think so. Correct, might be. And if it
If
is
we
sufficient, and
if
even
we
the,
think of ARDS, we have to dry the lung also itself. In that case, diuretic therapy is indicated. If we think of ARDS, as
Yeah.
because the PF ratio is less than 100, severe ARDS
Yeah.
is indicating the PF ratio. If I am not wrong.
But usually
Yeah.
the kidneys are normal in these patients. If the kidney is normal, they will pass urine automatically on its own. But yes, if the patient is not passing urine due to hypotension or some sort of, vasopressor requirement is already on, very high vasopressor requirement, and patient is vasodilated. So these are the situations where the kidney perfusion is compromised and probably this patient may have AKI or diuretic therapy may be required. But this is definitely a gray area, and this
Yeah.
answer may not be right that diuretic therapy is indicated always. It has an individualized therapy. You can give a trial of diuretics, and if the diuretics help your patient, you can continue. And your attempt should be to keep a negative balance. Okay.
And sir,
That's
if I
correct.
said it is trolley, then corticosteroid should be true with the trolley, no, sir?
Yeah,
It's false.
corticosteroid therapy also should be given.
Should be three, but yes, no, sir, answer is
Yeah, this may be a wrong answer, but yes, corticosteroid is also recommended, especially if the patient is hypoxemic, not
Yeah.
for mild ARDS. If the patient has severe ARDS and is hypoxemic, and this patient is requiring 100% oxygen, very high PEEP, corticosteroids are recommended. You got it?
Yeah, thank you, sir.
I hope you enjoyed the discussion, and
Really,
hope to see you again. And good luck to you all for your
Thank you,
upcoming
sir.
exam.
Thank
Thank
you
you, sir.
very much,
See you next
sir.
time.
We
Thank
really
you, sir.
enjoyed this session.
Oh, sure. Thank you. Thank you. My
Thank you,
pleasure.
Thank
sir.
you, sir. Thank you, sir.